This is the outline of my talk. I will present a case, follow it up with medication that can or aggravate steatotic liver disease. I'll talk a little bit of hepatic drug metabolizing enzymes and transporters in NASH. And the next address this question, whether NAFLD patients have increased susceptibility to DILI as a risk factor for DILI, and also if DILI is associated with a worse outcome in MASLD. So this is a case, a young man, 29 years old, BMI 20, underwent right hemicolectomy for adenocarcinoma of the colon. And they was treated with 6 cycles of oxaliplatin and capecitabine. 4 months after adjuvant therapy, he presented with jaundice, and as a diagnostic workup for drug-induced liver injury, all viral and autoimmune markers were negative. Ultrasound and CT was normal. You can see here at baseline the liver function tests were normal, but during chemotherapy, you find that the bilirubin has increased to 6 and the AST-ALT mildly to 75 and 80. And over the course of his chemotherapy, the bilirubin continued to be stable at around 6. Briefly, it dropped down to about 3.2 with raised AST and ALT about 3 to 4 times normal. He underwent a liver biopsy, and you'll notice here that he had significant micro as well as macrovascular steatohepatitis with ballooning degeneration. So after finishing his chemotherapy, 2 months after that, you notice that the bilirubin is almost touching normal with normal enzymes. And 9 months later, and now after 5 years, his liver function test continues to be normal. So what does this all mean? It means that this patient developed a de novo occurrence of non-alcoholic fatty liver disease during chemotherapy. And with resolution, there was resolution after cessation of chemotherapy. The question is, can medications cause steatotic liver disease, or can it aggravate steatotic liver disease? The answer is yes. And there are few drugs that can be stratified into 3 groups. Drugs that can cause more severe acute liver injury, and you have many of these drugs listed here. At the bottom, you find that troclitazone as well as telithromycin were withdrawn from the market because of its propensity to cause acute liver failure. Then there are drugs that may favor the transition of pre-existing fatty liver disease. And in addition to steroids, you find that the other 3 drugs are irinotecan, methotrexate, as well as tamoxifen. And finally, in the third group, you have drugs that may worsen pre-existing fatty liver disease. And again, you have androgenic steroids and corticosteroids, and again dominated by the chemotherapeutic drugs, tamoxifen, methotrexate, and irinotecan. Now, when patients receive chemotherapy and they develop fatty liver disease, it's called CASH, or chemotherapy-associated steatohepatitis, and there are a few drugs listed there. But there's also another entity known as LASH, and that is lactic acidosis steatohepatitis, and these were what we saw in the initial years of HIV, where patients exposed to stibudine diadenosine were also noticed to have LASH. This also, we have to remember that the current antibiotics that we use is linezolid, rarely can also produce LASH. Now, a lot of research and publications on the clinically important alterations, pharmacogene expressions, and I have listed 3 of these publications here for those who are interested, summarizing hepatic drug metabolic enzymes and transporters in NAFLD disease. And you'll find this in this slide, that in patients who have non-alcoholic fatty liver disease, you have perturbations in both the influx as well as efflux transporters, and also a significant impact on the CYP enzymes, and particularly on the CYP2C19, which acts as a substrate to many of the drugs. One important example is clopidogrel. So the patients who take clopidogrel or any other drugs have a decreased response to the drug when they have non-alcoholic fatty liver disease. So how does NAFLD or NASH increase susceptibility to DILI? And this is that increases because of its impact on CYP2E1 with increased reticulooctavial system, TNF-alpha increase, ER stress, mitochondrial dysfunction, and as I mentioned earlier, altered transporter expression. Simplifying mitochondrial dysfunction, if you have these drugs that you take, it impacts on the beta oxidation of fatty acids. It also impacts on the respiratory cycle chain. If the disease is mild and if you withdraw the drug, you have reversal of the disease from steatosis. But if the disease is far advanced, then it's cell dysfunction, cell death, as well as lactic acidosis. The next question is, do patients with NAFLD have increased susceptibility to DILI? And I'll go through about 3 or 4 slides. These are a multi-center study on the incidence and risk factors of MASLD in an Italian cohort who received tamoxifen as chemotherapeutic trial. You find that there are 52 centers and there were more than 5,000 patients. And they noticed that those patients who had underlying NAFLD had an incidence of DILI of about 1.2% versus 0.7% of those who did not have NAFLD. Now, importantly, although they found that the cumulative incidence was about 2 times in those patients who had NAFLD, they found that if the body mass index was more than 30, it actually reached about 4. If the body mass index was anywhere from 25 to 30, then the cumulative incidence was just over 2. And if the body mass index was less than 25, in other words, if the patient did not develop NAFLD obesity, then it was about the same. The next study is on the association between antipsychotic-induced elevation of liver enzymes and weight gain. And we all know that those patients who are on antipsychotic drugs tend to put on a lot of weight. And here also they noticed that, here you will notice, that those AST, ALT elevation are noticed only on those patients who had a weight gain of more than 7%. And when they compared it to those who had less than 7%, the AST and ALT remained normal, thereby suggesting that patients who take antipsychotic drugs go on to develop increased weight, and it's sometimes difficult to disentangle the effect of obesity as well as the effect of drugs on these patients. An important study published by Naga Chalsani and his colleagues from Indianapolis, and these are healthcare workers. So they had 3 groups. One is, these are called as quasi non-alcoholic fatty liver disease because they excluded all cases of hepatitis C, B, alcohol, etc. And they had 2 controls. One control which had those who had an ALT less than 45, and another control those who had ALT less than 31. And they looked at all the top 10 medications that were common in the US. Now, they had, as I said, they had 2 groups, and you had the suspected or quasi non-alcoholic fatty liver disease. Baseline, they had an ALT of 69 compared to 19 and 17 in control 1 and control 2 group. But importantly, you found that those patients who had suspected non-alcoholic fatty liver disease had an incidence of 0.8%. In other words, it was 4 times more than those who are 4 times more than the control group. This study was replicated in 2 other studies. In the bottom, you'll notice actually an Italian study published several years ago, which did not gain much attention, where they showed that the non-alcoholic fatty disease patients were significantly associated with DILI with an odds ratio of 3.95. But I particularly like the Asian study, South Asian, because this is a population-based study on several thousand patients. And they looked at the DILI incident. They found that the risk of DILI before the diagnosis of non-alcoholic fatty liver disease was 3.8. And after the diagnosis, the incidence rate ratio was 7.04. It actually doubled. And there's a recent study of non-alcoholic fatty liver disease as a potential risk factor for immune checkpoint inhibitors. And you'll notice here on univariate analysis, this is from Japan of 134 patients, and 8 of them went on to develop DILI. And on a univariate analysis, the hazard ratio was 6, but on a multivariate analysis, it's 29.34. The next question is DILI associated with the worst outcome in non-alcoholic fatty liver disease? And this is the next 2 slides are on the drug-induced liver injury registries. So this is the DILI registry, where they had 899 patients, 89 with known pre-existent liver disease. No pre-existent disease was 810. So you had a mortality of about 16% in the patients who had no existent liver disease. Mortality was 5.2 for those who had no underlying liver disease, and that was significant. But why did these patients die? You found that a majority of the patients actually died, of 57% from liver-related mortality, and those who had no liver disease died less, and again it was significant. This was replicated again in a Spanish DILI registry, and that you will notice that the liver-related death was about 7.5% in their group compared to 1.8%, and that was significant. So in conclusion, non-alcoholic fatty liver disease associates profound changes of drug metabolizing enzymes, activity as well as expressions. There are medications that can cause and aggravate non-alcoholic fatty liver disease / NASH. Non-alcoholic fatty liver disease patients have increased susceptibility to drug-induced liver injury. DILI is associated with worse outcome in non-alcoholic fatty liver disease.